I have the honor of introducing Micheal Milward, who has been at Hospice of Santa Cruz County for about 4.5 years. And we've loved what Mike has brought to our Hospice of Santa Cruz County. He was a hospice chaplain for 16 years. And before that got a law degree somehow in there. Amazing. He is an aspiring guitar player, and that's plenty.
Thank you, Jen.
And it's wonderful to have you here with us. Thanks.
Thanks, Jen. And good morning, everybody. Congratulations. You've chosen wisely today. This opportunity to learn some hard things is really important. And thank you all for taking your time. We're all really busy, and so it's really great to see all of you here. You know, both as the CEO at Hospice of Santa Cruz County and in my experience as a hospice chaplain, I get to speak to a lot of different groups. And I often start with an observation by a Boston journalist by the name of Stephen Kiernan, who says, in the last 20 years, perhaps the greatest transformation in our culture has been in how we die. And what he means by that is that in America today, we die gradually. He points out that in 1900, 90% of us died from some sudden acute illness or event. Today, 90% of us will die from some chronic process or comorbidities. So this conversation is really important. We also know that some 80% of us say that we want to die at home, surrounded by our friends, our family, those that we love, with our pain and symptoms managed aggressively. And we know that nowhere near this number gets that wish. Far too many folks spend days in the ICU within 30 days of their death. We also hear about studies like the one that Dr. Gawande talked about when I was in Boston 1.5 years ago. And we've heard many of these studies now. This is from Mass General, 400 lung cancer patients, all terminal. They lived an average of 11 months. 200 were attended by traditional oncology. The other 200 by traditional oncology and palliative care. The 200 with palliative care stopped treatment sooner, entered hospice earlier, and lived 25% longer. And this was not a one-off. We see these studies coming out more and more. So this is what we're here today about, to talk about how to have conversations with patients earlier, have better conversations, have more conversations about goals and values. I'm going to say more about that when I get to introduce Dr. Bernacki in a little bit. For now, Dr. Elizabeth Brenner is with us. She's going to talk to us about hospice eligibility and palliative care. So we have some context for our conversation today. Dr. Brennan is board certified in hospice and palliative medicine. She's been working in that area for the past 15 years. That makes her a pioneer. She's also one of our treasured medical directors at Hospice of Santa Cruz County. Without further ado, Beth Brennan.
Hi, good morning, everybody. I was just to give a little brief introduction about hospice and palliative care eligibility, part of which we think is important because when you have these conversations, you need to know how to talk with your patients about what these things actually are. And there still is a lot of confusion about what's the difference, what's the overlap, what does this look like? And thankfully in our community, we have a robust, I would call it a robust growth of both of these. So first, let's talk about palliative care. I want to acknowledge that palliative care is something that doctors and nurses and providers have done since the profession started, right? It's taking care of patients' symptoms, making them feel better, and palliating the symptoms of their disease. So that's something that we all do. As a specialty, which is a more recent construct, palliative care is something that's provided by a team of palliative care physicians, nurses, and other specialists, physical therapy, speech therapy, chaplains, who work together with a patient's other doctors to provide an extra layer of support to what's happening to them already. It's appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment, chemotherapy, surgery. That's what the palliative care specialty, and when we often talk about palliative care nowadays, that's what we're talking about. Palliative care in our community can be provided both inpatient and outpatient, and physicians are now trained in fellowships to do symptom management and goal clarification and the other tools that are needed around this particular type of medicine now. Hospice is really a direct care organization. It's similar to home health, and I like to call it home health platinum, because there are much more that it provides than home health services. It does provide direct medications, nursing care, DME, wheelchairs, beds, some caregiving needs, but as all of you know, not 24-hour caregiving needs, but some bathing and dressing needs, spiritual care, caregiving support to the family and the people who are helping to care for the patient. And the one thing it provides is 24-hour resources for urgent and emergent needs. And that is hard to provide in our system of medicine outside of the hospice benefit. So that's one of the biggest pieces that people need when they come on our services. It provides care to patients who meet certain criteria. Some of you know the criteria are designed by Medicare, and there's certain criteria that suggest a patient has a prognosis of 6 months or less. They are somewhat based on real science and some not. So they're interesting criteria, but what I want to stress is that none of them are hard and fast, because we rarely have a patient who comes with just one disease who meets all the check boxes, because they come with one disease and they have this one. And so maybe they meet some of the criteria here and some of the criteria here, and if you look at the whole picture, you know, we as physicians can say, this is where we are. The care provided on hospice is, and this is a specifically non-specific term, supportive rather than life-sustaining, okay? And what that means really is dependent upon the patient. I like to say that all things can be discussed, so if you're referring to hospice, refer and call us, call the medical directors, and we'll talk about what is reasonable and right and what the patient needs to make sure that they're symptomatically taken care of and their quality of life is the best that it can be. So if you have any questions about does my patient need hospice or palliative care, reach out to your resources in your community, and we'll all learn as we go. And the goal is to make available these resources to patients and their care teams earlier. We do know that these services can be very useful to people, and we are often having them to patients later than they could have them because of some fear around the definitions, the names, some not knowing that the systems are available. So if you're at all concerned and you're out there and you're wondering whether this would be right for your patient, an early phone call is great, okay? You can't choose something that you don't know is an option. So that's part of what today is about, right? To talk to patients and let them know what their options are so that they can make informed decisions. Thank you.
So we have an upcoming Medi-Cal palliative benefit, and Dr. Dale Bishop, who's our Chief Medical Officer at Central California Alliance for Health, will walk us through this quickly. It's not a current benefit, so it's kind of a heads up. And Dale joined Central California Alliance for Health about 3.5 years ago, and you have been just such a treasure for us, so collaborative in our community, and just a forward-thinking person, and we appreciate you greatly.
You're always too kind to me, Jen. I only have a couple minutes here, but I just wanted to let you know, it's basically an announcement that Medi-Cal has approved a palliative care benefit for the Medi-Cal managed care units, and basically we are putting together with a plan to go live in April of 2017, the benefit. So the state has given us this care model for the benefit, and you can see that palliative care kind of fits in between early palliative care and disease-modifying care and hospice. So I think they're talking about having it be about a 1-year estimate before someone might die. So the definition, I think Dr. Brenner kind of covered this. So they're giving us some draft guidance on some of this. I just thought I'd share some of this for you. So their draft guidance has things like starting to use the hospital or the ED to manage their problems. They're starting to decompensate somewhat. Then the late stage, declining status, following appropriate therapy, and not yet in hospice, and willingness to engage in these programs. They have given us these minimal qualifying diagnoses. At the Alliance, we're planning to probably offer more than this, but this is the minimum qualifying diagnosis for the state's program. And the components of the program include advanced care planning, initial assessment and consultation, care plans, care coordination, etc. So again, 24/7 support is something Dr. Brenner mentioned, which is important also. So and still having access to curative disease-modifying care. They have a number of settings and providers that they're wanting this to take place with. We are looking to contract with providers now who can offer all of this whole package, not just one or two components. So that's kind of our job over the next 5 months to put together a panel of providers that you all can refer to when you need palliative care. So that's in a real rapid fire review. That's what we're going to be working on. So any questions at all? Yes.
Do you imagine only contracting with providers who can do the whole package, or do you imagine fee-for-service, social worker, spiritual care option?
So the question is, do we plan to provide contract with those that can offer the whole package, or kind of componentized options? I think ideally we're going to be looking for people who can do the whole package, or at least most of the package. I think, in order to get access, we may have to stretch that somewhat in some of our regions, but ideally, as much as we can put together for the whole package is going to be important. I think at least the assessments follow up in the care management portion. I think the care management piece is really, really critical for this. So I think we'll be working with you on that, and I think that's some of our challenges over the next few months to figure that out. All right, thank you.